the tests don't determine whether it is COVID. Once COVID is proven, then we look at the test. The test, suppose your C-reactive protein is high, it can be high in any acute illness. Suppose somebody has falciparum malaria, we have seen his D-dimer is high, IL-6 is high, C-reactive is high. So that doesn't determine you have COVID. What it determines that you have acute insult to the body, you have acute inflammation. What is the etiology of that inflammation? Only the clinician and COVID tests will determine.
So my question to you again, Avinash, that people see 4 factors, CRP, IL-6, D-dimer, and Ferartin. Can you tell us that in many conditions this can change? So ultimately it is between the patient and the doctor, and not patients should not get panic looking at the figures. It's the doctor who checks them, can tell them what is the situation.
Yeah, see, Sandesh, you are absolutely right. Barring intensivists or pulmonologists, the test interpretation is difficult even for an average physician. Forget the patient. For example, I will tell you, C-reactive protein rises very fast and comes down very fast, while ferritin will rise more slowly but will come down after months. Now, D-dimer borderline elevations don't mean anything. So what we rely on, as Salil and Kushal will tell you, is an increasing level. So suppose your C-reactive was X or D-dimer was X, IL-6 was X, and it becomes X plus double in 2 days. That has more value than a single reading, and we correlate it with patient's clinical symptom. One thing I wanted to tell you, I have seen this IL-6 reports going wrong heavily. The reason is if you don't collect in EDTA vacuotenor and run the test immediately, the transportation from plain tube can elevate the IL-6 value almost 50-fold.